Hello, it's Dmitry again. Today we'll be doing a video on the Mehlman Medical PDF for internal medicine, now looking at the renal section for this video. This is a chapter, you could say, that's from page 77 to page 103. So we might cut this up into two videos, or we might keep it in one. We'll see how it goes. I suspect it would be two. Perhaps even three, who knows? Let's see. Internal medicine, renal. Basic high-yield renal lab values for internal medicine. Blood urea nitrogen, BUN, should be less than 20 mg over deciliter. High urea nitrogen in the blood is called azotemia. Uremia technically means urea in the blood, but is used to refer to patients who have symptomatic renal failure with poor lab values. This has absolutely zero to do with hyperuricemia or gout, and is sometimes confused by students. Creatinine, or CR, 0.7 to 1.2 milligrams per deciliter. Once you've hit a creatinine of 2, you've lost 90% of your renal function. Well, that's pretty serious. Potassium, K+, 3.5 to 5.0 milliequivalents per liter, will always be elevated in renal failure on USMLE. This is because the kidney normally secretes, that is to say, excretes through the tubular walls into the urine, potassium in the cortical collecting duct under the action of aldosterone. So if the kidney is messed up, we can't do that, so serum potassium rises. Sodium, Na, 135 to 145 milliequivalents per liter, can be variable in renal failure as per my observations on NBMEs. Aldosterone normally reabsorbs sodium in the cortical collecting duct in exchange for potassium being secreted, so one might think it should automatically be below if the kidney cannot reabsorb it. But the kidney has a multitude of sodium regulation mechanisms, that is to say vasopressin, so the sodium can be normal. Calcium, always decreased in renal failure. This is due to two reasons. One, calcium is normally reabsorbed in the late distal convoluted tubule DCT, so if we can't do that, the serum calcium falls. 2. Proximal convoluted tubule, or PCT, of the kidney is normally where the 1-alpha hydroxylase, under the action of PTH, activates inactive 25-hydroxy D3 into active 125-hydroxy 2D3. The latter then goes to the small bowel, where it elevates the absorption of calcium, so if we can't do that, serum calcium falls. Low serum calcium means a decrease in negative feedback at the calcium-sensing receptors at the parathyroid glands, which causes the parathyroid glands to go up. To increase, right? Parathyroid hormone increases in that context because there's less negative feedback. We call this secondary hyperparathyroidism, which means that PTH is high due to the cause external to the parathyroid glands themselves. You need to know secondary hyperparathyroidism is due to renal failure. Phosphate, PO4 3-. Always elevated in renal failure. This is due to two reasons. One, the kidney cannot filter it out sufficiently. Lots of phosphate is normally filtered by healthy kidneys. PTH normally acts to decrease the phosphate reabsorption in the PCT via the downregulation of 3 different types of phosphate pumps. Since the function of PTH is impaired, the kidney reabsorbs too much phosphate, so the serum levels rise. Combination of decreasing calcium and an elevation in phosphate in renal failure equals secondary hyperparathyroidism. Bicarbonate, always decreased in renal failure. This is due to two reasons. One, the kidney cannot reabsorb bicarb in the PCT as well, so the increase in bicarb in the urine causes a decrease in bicarb in the serum, which leads to metabolic acidosis. 2, the kidney cannot secrete protons in the cortical collecting duct as readily, which means the retention of hydrogen mops up the bicarb, leading to a decrease in serum bicarb. Renal failure equals uremia, the U in mud piles for the high anion GAP metabolic acidosis. If you need help on this acid-base stuff, do my high-yield arrows PDF. Let's talk about afferent versus efferent regulation. Afferent arterioles go to the kidney. Latent patency maintained by vasodilating prostaglandins. NSAIDs inhibit the prostaglandin synthesis. leading to a decrease in dilation of the afferent arterioles, which leads to a decrease in renal blood flow. The NSAIDs don't actively constrict the afferent arterioles. This is incorrect wording. They just merely decrease vasodilation, decreasing the diameter of the afferent arteriole. Okay, so that's a funny phrasing. It doesn't vasoconstrict the arteriole, it just decreases its vasodilation. Is there another word we can use for that? I don't know. It becomes like a word game at that point where it's like, okay, it's not vasodilating it, it's not vasoconstricting it, it's just decreasing vasodilation. Okay. But the effect, whatever phrasing or terminology or framework you are using psychologically to describe the underlying reality that we're talking about, the effect is the same, right? Efferent arterioles leave the kidney. Angiotensin II normally constricts these. ACE inhibitors and angiotensin receptor blockers, therefore, increase the diameter of the efferent arterioles. They are not dilating them. They are merely decreasing the constriction of them. Okay, the phrasing is ridiculous. It's crazy. It's not dilating it. It's just reducing constriction. Okay, for all intents and purposes, that's called dilation. Okay, functionally speaking, that's a functional form of dilation. It's like saying we're not. I don't know. It's sort of like this framework thing. It's like, okay, the plant is not growing. It's just reaching its full height. It's like, okay, but that's what that is. Whatever. I understand what the distinction they're making, but it's a little bit pedantic in my opinion. They are decreasing constriction of them, but constriction of them. As mentioned above, prostaglandins will actively dilate afferent arterioles. Prostaglandins actively dilate afferent arterioles. Okay. Some students might say, well, doesn't angiotensin II act on the afferent arterioles as well? In theory, a very minor amount, but on USMLE, will get your question wrong. You want to think, summary, angiotensin II equals constricts efferent. ACE inhibitors and ARBs decrease constriction of efferent, that is to say, increase diameter. So I just say that they do dilation. I hate this decreased constriction. No, it functionally dilates. You're being pedantic a little bit here, okay? And this is a criticism. This is my critique right now. Anyway, angiotensin II constricts efferent. ACE inhibitors and ARBs functionally dilate the efferent by increasing the diameter. Prostaglandins actively dilate afferent. And NSAIDs functionally constrict the afferent, decreasing the diameter. So, NSAIDs, functional constriction of the afferent arteriole. ACE inhibitors, functional dilation of the efferent arteriole. Prostaglandins, active dilation of the afferent arteriole. And angiotensin II constricts the efferent arteriole. Directly constricts the efferent arteriole. So when they say decreased constriction, they mean functional dilation. When they say decreased dilation, they mean functional constriction. They will say, no, it's completely different. I'm using the word functional here just to kind of give a little bit of wiggle room, because I understand the point they're trying to make here, but it's very, very, very pedantic. And I really don't think it bears you much utility to make little minor distinctions like that for all intents and purposes when you're trying to do something on these exams. They're not going to ask you, is this a decreased constriction or is this a dilation? They don't, that's not going to help you. I think that pedantry is going to make things more confusing for people. So anyway, pre, intra, and post-renal azotemias. BUN/creatinine, FeNA. So BUN/creatinine over creatinine, blood urea nitrogen to creatinine ratio, FeNA, fractional excretion of sodium, so functional excretion of sodium, i.e. the amount of sodium in the urine. There is no normal range you have to be looking for here for either of these. What is more important is that there is an actual kidney problem. We look at the values to help us figure out the diagnosis. But we never actually say, the BUN creatinine or the functional fractional excretion of sodium is out of normal range. We don't do that. We say, oh, there's other issues. What can we use these to figure out about it, right? We only start looking at this stuff when we have a problem, and we're trying to figure out what's going on. BUN over creatinine is greater than 20, and then the functional excretion of sodium is less than 1%. This means pre-renal azotemia. But what if the opposite's the case? What if the BUN over creatinine is low, below 20, and now the functional excretion of sodium is greater than 1%? Just simply means not pre-renal. Maybe it's post-renal. Maybe it's renal, but it's not pre-renal in that context. The notion of intra versus post-renal having slightly different ranges is nonsense for USMLE. Also, I've come to learn from the NBME questions that only 9 out of 10 times the BUN creatinine will be what we expect. There are a couple of 2CK NBME questions that give a BUN creatinine less than 20 for pre-renal azotemia and greater than 20 for acute tubular necrosis. If the NBME ever breaks the rules this way, the vignette will be overwhelmingly obvious that what the diagnosis is anyway. So it's not perfect, but it's probably going to be true 90% of the time, if not more. And it'll be pretty obvious if you knew what you're reading about, that one thing is the exception rather than the rule. So let's talk about it. Pre-renal. Yeah. Pre-renal azotemia means there is a renal pathology because of reduced renal blood flow over the subacute to the chronic time frame. The kidney will do everything it can to increase the retention of fluid because it thinks blood volume is low. The way it accomplishes this by increasing the reabsorption of urea and sodium, since water will follow. This is why blood urea nitrogen is high, that is to say BUN creatinine is greater than 20, and the sodium in the urine is low, the functional excretion of sodium is less than 1%. Notice above I stress subacute to chronic time frame, i.e. days and months, since one of the highest yield points you need to know is that USMLE is that the acute decreased perfusion, i.e. seconds to minutes to the kidneys from the blood loss, acute heart failure exacerbation, or arrhythmia, i.e. VFib for 30 seconds before resuscitation, causes acute tubular necrosis, not pre-renal. This is all over the NBME exams. For example, if they say a guy loses lots of blood during surgery and receives 20 packs of RBCs, then 2 days later while recovering in the hospital, he gets oliguria plus deterioration in the renal function. The answer is acute tubular necrosis, not pre-renal. Students say, wait, but there was a decrease in renal perfusion though. So how does that make any sense? Isn't pre-renal caused by decreased perfusion? Well, the PCT of the kidney is the most susceptible to anoxic-hypoxic injury due to the increase in concentration of ATPase transporters. So the acute drop in the blood flow means acute hypoxia, PCT sheds. There's a 2CK NBME question where they mention a guy post-op who had not lost any blood during surgery, plus had not experienced any episodes of low blood pressure, plus was started on ketorolac, which is an NSAID, for pain post-operation, now has oliguria and an increase in creatinine. The answer should be hypoperfusion as the cause. This is an example where the NSAIDs, not acute tubular necrosis, can cause post-op oliguria from pre-renal. High-yield cause of pre-renal for USMLE are NSAID or diuretic use, chronic left heart failure, or dehydration from days of vomiting and diarrhea. USMLE will give patient who's been on NSAID, naproxen, for several weeks, or who has commenced on furosemide, loop diuretic, a few days ago. The vignette can give a patient who was on an NSAID now, plus peripheral edema. They ask why there's edema. The answer should be decrease in renal excretion of sodium. This is because the PCT elevates the reabsorption of sodium in pre-renal functional excretion of sodium less than 1%. They will also sometimes give NSAID plus edema plus ask what you do, and the answer is just discontinuation of ibuprofen. Intrarenal, essentially synonymous with acute tubular necrosis on USMLE, the kidney can't reabsorb urea and sodium as easily, so BUN is lower, that is to say BUN creatinine is less than 20, and sodium is higher than the urine, i.e. the functional excretion of sodium is greater than 1%. I discussed acute tubular necrosis in more detail in its own table below, but as I mentioned above in red font, The most important point for USMLE is that you remember the acute drop in perfusion to the kidney causes acute tubular necrosis, not pre-renal. I need to be a jerk and inculcate that. Again, let me read that again for you right now. It says here, an important point for USMLE is that you remember that the acute drop in perfusion to the kidney causes acute tubular necrosis, not pre-renal. Acute tubular necrosis of the kidney. It's not pre-renal. Different thing. Intrarenal. It will present differently. Post-renal. Almost always due to BPH on USMLE, but can also be due to ovarian or cervical cancer impingement on the ureters. What you need to know is that the old dude plus high creatinine equals BPH till proven otherwise. The answer on USMLE is often just increased Bowman's capsule hydrostatic pressure. Next up is to insertion of the catheter to relieve the urinary retention, even if the patient has bacteriuria, i.e. choose catheter insertion over antibiotics. Another 2CK question has a check post-void volume as the answer in elderly male with high creatinine. USMLE won't force you to choose between the catheter insertion or checking post-void volume. Normal post-void volume is less than 50-ish. If the USMLE wants overflow incontinence, they'll give you a post-void volume of 300 to 400. Diabetic neurogenic bladder, i.e. hypotonic bladder from neuropathy to the detrusor muscle, can also lead to overflow incontinence and post-renal azotemia, but as I said, most questions on USMLE will focus on the old dude with BPH. Hydronephrosis can be seen as large dilated kidneys in patients with obstruction, but this is a rare diagnosis. Nephritic versus nephrotic syndromes. Nephritic conditions have a blood in the urine. Nephrotic syndromes do not. You need to memorize for USMLE which high-yield conditions are nephritic versus nephrotic. Don't worry, I keep things real clean and concise in the tables below without the nonsense of other resources. There are 4 main points you need to memorize as being part of each syndrome type. Nephritic syndromes. What's part of nephritic? 1. Hematuria or blood in the urine. 2. Oliguria or decreased urinary output. The definition is less than 400 milliliters per day, but USMLE doesn't assess that number. Azotemia. Number 3 is azotemia, elevated blood urea nitrogen. This is because the urinary output is decreased. And number 4, hypertension, elevated RAS due to the inflammation of the renal microvasculature. So that's nephritic syndrome presentation. What about nephrotic syndrome presentation? Proteinuria, number 1, proteinuria. Nephrotic level by definition is greater than 3.5 grams per day, but USMLE won't assess that number. Hypoalbuminemia due to the prolonged. Number 2, hypoalbuminemia due to the proteinuria will be less than 3.5 grams per deciliter, but USMLE doesn't care about that number. Okay, so it's also the 3.5 thing. It's less than 3.5 before we're talking about the proteins is greater than 3.5. So hypoalbuminemia will be 3.5 or less than 3.5, but the actual protein amount being expelled will be 3.5 grams a day. So, well, it's a little bit, it's not that confusing, but you get the idea, hopefully. Number 3, peripheral edema due to the hypoalbuminemia. Decrease in serum oncotic pressure causes transudation of fluid into the interstitial spaces. Severe can present with ascites. The SEM says pre-sacral edema. This is a nephrotic syndrome until proven otherwise on USMLE. Number 4, hyperlipidemia. Liver pumps out apolipoproteins in an attempt to preserve serum osmolality and oncotic pressure. It should be noted that the nephritic syndrome often have proteinuria, just as usually not at nephrotic level. So it has to be less than 3.5 grams a day to be nephritic. Nephrotic is when you go above that 3.5 threshold. Students sometimes erroneously think that nephritic syndromes don't have proteinuria because it's not part of the 4-point categorization above. That's just simply not true. You don't have to worry about the notion of which conditions are both nephritic and nephrotic. What is really most important is simply know which conditions have hematuria and which ones do not, via tables below. Nephrotic syndromes can increase the risk for DVT, renal vein thrombosis, and varicocele due to the loss of antithrombin 3 in the urine. Yeah, that's crazy. So it can actually cause these issues with the clotting. You have a hypercoagulable state because you're losing this antithrombin 3. This is because nephrotic syndrome usually entails non-specific massive protein loss due to the loss of size and charge barrier. Antithrombin 3 is a protein. So the NBME wants you to know that the left renal vein thrombus accretion from the hypercoagulable state can cause varicocele. So here's the actual nephritic syndromes, and I assume we go nephrotic syndromes after that. I'm going to go take a break, skip ahead if you're watching the video, and I'll come back to you after that. high-yield nephritic syndromes. Post-streptococcal glomerulonephritis, or PSGN, aka proliferative glomerulonephritis. The latter is asked on NBME, where there is a vignette of PSGN, and the answer is just proliferative glomerulonephritis. Students are like, what the heck? AKA proliferative glomerulonephritis. Okay. Answer can sometimes be written on NBME as just acute glomerulonephritis. Well, that's even more confusing. Acute glomerulonephritis. The answer on USMLE for red urine 1 to 3 days following a sore throat caused by group A strep pyogenes. This is in contrast to the IgA nephropathy, which I'll discuss in detail below, which is red urine 1 to 3 days following a sore throat. PSGN can be caused by skin infections. Can be impetigo or school sores, cellulitis or erypselis. I discussed these in detail in my high-yield derm PDF. For example, the question might say a 10-year-old has a yellow crusties on his arm for the past 7 days, impetigo, plus now has red urine. The answer should be acute glomerulonephritis. Type 3 hypersensitivity, antigen antibody complexes that form in blood and deposits in the kidney. Don't confuse with rheumatic heart disease, which is a type 2 hypersensitivity. Type 2, what is that? HS. Medical type 2 HS. Hypersensitivity reaction. Hypersensitivity, some sort of hypersensitivity, I would assume. Where was I? Type 2 HS. Serum complement protein C3 can also be decreased in lupus, but unrelated, specifically SLE, but unrelated. Streptolysin O or A titers will be elevated. PANDAS is tested on 2CK, pediatric autoimmune neuropsychiatric disorder associated with streptococci, presents as a new onset tic/Tourette, OCD, or ADHD within weeks of group A strep infection. Descriptors such as subepithelial deposits or lumpy, bumpy appearance on electron microscopy, EM, etc., have been parroted across resources over the years but are essentially garbage for USMLE. PSGN usually self-resolves in kids without sequelae, but the USMLE wants you to know that the elevated age means a worse prognosis, where the chance of renal failure is elevated if it occurs in adults. This is probably related to the more robust immune response resulting in more advanced renal damage. IgA nephropathy, aka Berger disease. AKA Berger disease, IgA deposition and renal mesangium, red urine 1 to 3 days after a sore throat. This is in contrast to PSGN, which is red urine 1 to 3 days after a sore throat. I just mentioned it above, obviously, but students can mess this up despite the inculcation, so I'm reiterating it like a jerk. Caused by viral infection, not group A strep. Can sometimes be caused by GI infections, but USMLE usually avoids this etiology unless including it in the Henoch-Schönlein purpura constellation. Henoch-Schönlein purpura is a classic tetrad of palpable purpura, usually on buttocks and thighs. 2. IgA nephropathy, red urine. 3. Arthralgias, and then 4. Abdominal pain. All four are not needed to present for Henoch-Schönlein purpura, but the abdominal pain component, there is presumably viral gastroenteritis leading to IgA nephropathy. The answer on USMLE for a male 20s to 40s with a hematuria and hemoptysis, similar to Wegener and microscopic polyangiitis, can cause RPGN, caused by antiglomerular basement membrane antibodies, anti-GBM, which are antibodies against collagen 4. Renal biopsy will show linear immunofluorescence. USMLE likes showing the bright green image for this. Oh, I'm sorry. So IgA nephropathy, we end on presumably viral gastroenteritis leading to IgA nephropathy for if you had the if you have some of the tetrad, basically. Let's talk about Goodpasture syndrome now. Goodpasture syndrome. Goodpasture syndrome, the answer USMLE for males 20s to 40s with hematuria and hemoptysis, similar to Wegener and microscopic polyangiitis, can cause RPGN, which is glomerulonephritis. But what kind is it called? RPGN? RPGN is called rapidly progressive glomerulonephritis. Okay. So it can cause RPGN, caused by antiglomerular basement membrane antibodies, anti-GBM, which are antibodies against collagen 4. Renal biopsy will show linear immunofluorescence. USMLE likes showing the bright green image for this. Do not confuse this with Alport syndrome, which is an X-ray condition, XR condition, caused by mutations in collagen 4. So that's a different situation. Okay, let's talk about it then. Alport syndrome, X-linked disease. So that's probably what they mean by the XR, X-linked disease, mutation in collagen 4 gene. Do not confuse with Goodpasture syndrome, which is antibodies against type 4 collagen. So this is a mutation in the collagen type 4 for Alport, while the Goodpasture is an antibody against it. Different situation. The answer in USMLE for a male who has red urine plus an eye and ear problem, type 4 collagen is present in basement membranes in the kidney, ear, and eyes. The eye problem can be blurry vision such cataracts. The ear problem will be neurosensory hearing loss due to the organ of corti dysfunction. Some students have asked if it's XR or XD. I think when they say XR and XD, they mean X-linked recessive versus X-linked dominant. So literature appears to be varied, but USMLE does not care. On offline NBME 18, however, it's mentioned in a question as X-linked recessive. You can memorize splitting of the lamina densa as associated with Alport disease. So MPGN, or membranoproliferative glomerulonephritis, the answer on USMLE for red urine in patient with a hepatitis C, heroin use, or malignancy. Descriptors such as dense deposits or C3 nephritic factor and duplication of basement membranes are basically nonsense for USMLE. Answer is renal biopsy as the next step for MPGN. This is as the next best step. Yeah, this guides our management. A 2CK internal medicine form has heroin as the answer, heroin-induced nephropathy for a patient with protein and blood in the urine. In contrast, FSGS, discussed below, from heroin has no blood in the urine. So for MPGN, blood in the urine, heroin, but for heroin related to FSGS, there will not be blood in the urine. DPGN, or diffuse proliferative glomerulonephritis, the answer in USMLE for red urine in the patient with lupus, again, SLE, can sometimes be associated with a wire looping or capillary walls, same as with the MPGN. USMLE wants renal biopsy as next best step since this guides our management. RPGN, or rapidly progressive glomerulonephritis, yeah, okay. Acute depression in renal function in the setting of vasculitis, that is to say Wegener microscopic polyangiitis or Goodpasture syndrome. I discuss these conditions in detail later in my PDF. Don't worry. Characterized by fibrin crescents on biopsy. And so you can see that biopsy for the RPGN right here. Looks like the Bauman's capsule. It was what I'm kind of getting a vibe of, but who knows? What do I know, right? But fibrin crescents for RPGN. High-yield nephrotic syndromes. Minimal change disease. The answer on USMLE for otherwise unexplained edema is in a kid who does not have blood in the urine. Presents as peripheral edema, periorbital edema, and/or ascites. Almost always this is pediatric. Very rarely can it be due to Hodgkin in adult. Classically post-viral, URTI, but 50% of the vignettes won't mention that. In other words, the textbook vignette is an 8-year-old who has the sniffles for 4 days, followed by peripheral and periorbital edema a week later, without blood in the urine. Once again, though, the STEM need not mention the viral infection, called minimal change disease because of the light microscopy LM shows no abnormalities. The EM, however, shows effacement of the podocytes. Mechanism for nephrotic syndrome is loss of size and charge barrier. Corticosteroids are the treatment and are highly effective. A 2CK question gives minimal change disease as an etiology for spontaneous bacterial peritonitis. That is to say, any cause of ascites can cause the SBP. Where are we? Okay. Spontaneous bacterial peritonitis. Yeah, any cause of ascites can cause it. I discussed this stuff on my GIT PDF in extensive detail. MCD, minimal change disease, aka lipoid nephrosis, lipid droplets can be seen in urine on LM. What about membranous glomerular nephritis / nephropathy? The answer in USMLE for nephrotic syndrome in patients who has a exposure to drugs, dapsone, gold, salts, sulfonamides, infection, hepatitis B, hep C can cause it too, but rare, and in visceral cancers, breast and pancreatic cancer, for example. Autoimmune primary, antibodies against phospholipase A2 receptor. The LM image is important and shows highly eosinophilic pink and inflamed thickened capillary walls. Can cause spike and dome appearance of subepithelial deposits on EM. Renal amyloidosis. The answer on USMLE for nephrotic syndrome in multiple myeloma. Amyloidosis means protein depositing where it shouldn't be depositing. Multiple myeloma is cancer of plasma cells that produce too much immunoglobulins, leading to a high serum IgG kappa / lambda light chains. Immunoglobulins are proteins which leads to these fly through the kidney and cause Bence-Jones proteinuria. They also deposit in renal parenchyma, causing renal amyloidosis. Biopsy shows classic apple green birefringence with Congo red stain. And see, here's the image right there for you. For some magical reason, USMLE cares that the amyloid appears this way because it is beta pleated sheets. That is to say, answering MBME, alpha helices is wrong. Beta pleated sheets, okay? Again, we're talking here about renal amyloidosis. Beta pleated sheets make sense since the former are flat and can be reflect light at different angles. An NBME question has renal parenchyma disease as an answer for kidney issue due to multiple myeloma. Renal parenchymal disease potentially is an answer. Okay. We're at 40 for time. Where does this cut off? Yeah, I'll cut it off there. That's fine. Diabetic glomerular sclerosis. Diabetes is the most common cause of chronic renal failure. Renal failure simply means a decrease in the glomerular filtration rate, or GFR. USMLE wants you the first two changes that occur in the kidney due to the diabetes as follows. 1. Hyperfiltration. Elevated glucose crossing the glomerular basement pulls water with it, leading to polyuria. Sometimes the question can just simply give you the diabetes plus they ask what's the most likely to be seen initially. The answer should be elevated glomerular filtration. Over time, the kidney will fail and GFR will decrease. 2. Thickening of the glomerular basement membrane, non-enzymatic glycosylation of the membrane, loss of size and charge barrier. Kimmel-Steele-Wilson nodules are composed of hyaline and look like pink circles on light microscopy. This image is very high yield. Hyaline arteriosclerosis is deposition of hyaline protein in the walls of the renal vasculature. Although this can be due to many things, on USMLE, they want you to know that this is caused by diabetes. ACE inhibitor, that is to say lisinopril, for example, or A or B, as I call sartan, are the first drugs to use in diabetes if there is a hypertension greater than 130/80 in diabetes, not 140/90. Proteinuria, or elevated creatinine or renin. Angiotensin II normally constricts the afferent arterioles, leaving the kidney, causing a backup of pressure at the glomerulus. This serves the purpose of maintaining GFR, i.e. filtration through the Bellman capsule where the renal blood flow has decreased. In other words, renal perfusion decreases, RAS goes up, angiotensin II goes up, and we get constriction of efferent flow leaving the kidney. This leads to filtration fraction increasing, GFR over renal plasma flow, where we have a GFR staying the same despite a decrease in perfusion. ACE inhibitors / angiotensin receptor blockers decrease the constriction of the efferent arterioles. They don't dilate. This refers to the action of prostaglandin on the afferent arterioles going to the kidney, thereby decreasing the filtration fraction and reducing GFR. This might sound like a bad thing, i.e., why would we want to decrease the GFR in diabetes if it's the most common cause of chronic renal failure? Well, the answer is because the slightly reduced GFR infiltration fraction early on decreases the rate at which the excess glucose is filtered across the glomerulus. Over time, it is inevitable that the glomerular basement membrane will non-enzymatically glycosylate and thicken, so ACE inhibitors and ARBs slow this process, i.e., slightly reduce GFR early in order to prevent a massive decrease later. Focal segmental glomerular sclerosis, or FSGS, the answer on USMLE for nephrotic syndrome and sickle cell, can also be caused by heroin and HIV, not as responsive to steroids as MCD is, even though there's a certain degree of analogy, there's a certain degree of similarity between FSGS and minimal change disease. It is different patient demographic pool, and it is also not responsive to steroids the way that MCD is. FSGS literally means some parts of some nephrons are affected. Again, focal segmental glomerular sclerosis. So some parts of some nephrons are affected. Focal, some glomeruli. Diffuse, all glomeruli. Segmental, part of the nephron. Global, all of the nephron. So for MCD, the real demographic for MCD is like a child, basically. But for FSGS, it is typically, to my knowledge, it's usually adults. And it's disproportionately black and potentially even Hispanic, although I want to confirm that. It's also going to be higher in people who are, I believe, drug users and heroin, and people who have HIV. So let me look it up right now. FSGS patient demographics. It says here, predominantly affects adults older than 40. Adults 45 and older, though it can occur at any age. More commonly, males, disproportionately black individuals who have an incidence rates of up 5 times higher than the general public, largely due to the APOL1 gene variants. Oh, okay. It says here, the incidence of primary FSGS is highest among blacks, Asian, and Pacific Islander populations. African Americans are roughly 5 times more likely to be diagnosed with FSGS than white populations. So it's also higher in Asians and Pacific Islanders. So maybe not Hispanics, but let me look it up right now just to confirm. Is FSGS higher in Hispanics? It looks like it actually is a little bit is higher. It says here occurs more frequently in Hispanic and black populations than in white populations, but I guess it might not be substantially higher compared to whites. I don't know. It says here Hispanic individuals also show a notably higher frequency of the disease compared to non-white populations, but again. It says here the APOL1 genetic variant plays a central role. People in Latin American descent who inherit these specific gene variants have an elevated risk of FSGS, and I think that is a African origin genetic variant or allele, which means that if you're Hispanic and you might have that because you that you might be part African descent. I would assume that's my intuition. So I'm gonna look up this is a detour, but I just want to know about this. APOL1 distribution. Sub-Saharan African ancestry and the African of diaspora. So i.e. black people and people who are part black. It's virtually absent in purely European or Asian populations. So basically the reason that people have it is because they are African or of partial African descent. Well, that's interesting. So you learn something every day, right? I thought it was just I wasn't quite sure. Maybe it's genetic, maybe it's not. But I also know that it's higher among people who do heroin and have HIV, which is not exactly something that Africans have equal levels of incidence compared to the European or other non-African populations in the United States. American blacks do have a higher incidence rates of HIV. And I don't know about heroin, but they do have a higher rate of, being arrested for drug use. And they do, so it kind of figures. So I don't know if it was purely like a behavior thing. If it's just like, oh, well, they just have more of these issues in their community, ergo, that's a bigger problem. It looks like it actually has a gene associated with it as well. So that is also a contributing factor. Possibly the predominant factor. So not quite 100% sure, though. Anyways, I'm going to take a break and come back to you. Skip ahead if you're watching the replay. Okay, I am back. So let's see. We have acute tubular necrosis. So basically, what I want to do today is just wrap up to probably page 90 and just call it a day, at least for this video. I'll pop back in for another video either today or tomorrow for this section, I would assume. Anyway, let's continue. Acute tubular necrosis. Sloughing of the proximal convoluted tubular tubular epithelial cells due to the chemical or ischemic result, insult. Only 50% of questions will mention the muddy brown granular cast or dirty brown granular cast or brown pigmented cast. That's a very key detail, but they only mention it half the time. The other 50% of questions will just mention oliguria or acutely worsening renal function in patient with classic ATN etiologies. Again, ATN as an acute tubular necrosis. Next best step in diagnosis, answer in 2CK form, is the measurement of urine sodium and creatinine concentrations. We expect the functional excretion of sodium to be greater than 1% and the BUN creatinine to be less than 20, almost always for acute tubular necrosis. So what can cause it? Well, ATN can be caused by drugs, aminoglycosides, gentamicin, tobramycin, amikacin, cisplatin, a chemo agent, or IV contrast. Any of the above drugs plus new onset oliguria or elevated creatinine, need not be mention of casts, means you probably have ATN. For instance, new NBME simply tells you the patient was given many drugs and now has a creatinine of 2, and our normal range would be 0.1 to 1.2. No mention of cast, plus they ask for what was given. The answer should be gentamicin, not hard. Patient who's recently been treated for endocarditis, but plus now has a new onset oliguria, ATN due to gentamicin. Empiric treatment for endocarditis is gentamicin plus vancomycin. New literature suggests vancomycin is not reliably nephrotoxic. Contrast nephropathy is exceedingly high yield on 2CK, where they want you to know that the adequate hydration prior to IV contrast is the number one way to prevent it. Adequate hydration prior to IV contrast. Number one way to prevent that. Okay. For instance, they'll say the patient got a CT plus now has an elevated creatinine, plus they'll ask you how it could have been prevented. The answer should be 0.9% saline or just IV hydration therapy. What's another cause for ATN? Rhabdomyolysis. Myoglobin is nephrotoxic. Big risk factors are alcoholism, falls, intense training, for example marathon, McArdle syndrome, statins, and fibrates. Rhabdo causes a false positive blood on urine dipstick. They will say the urinalysis shows a 2+ blood, but only 1 to 2 RBCs/HPF. This is because the dipstick can't differentiate between free myoglobin and hemoglobin and RBCs. One surgery question gives a 3 to 4 RBCs HPF as negative. I've seen this fool some students who already are aware of the false positive blood point about rhabdo. If the question wants positive RBCs, they'll say like 10 to 20 plus or HPF. Okay. The other half of rhabdo vignettes won't mention the false positive urinalysis and will instead just say oliguria. You need to know that this refers to the ATN. For example, an NBME favorite vignette is patient being found at the bottom of stairs in his or her house plus a false positive blood on urine dipstick and or oliguria. The answer should be rhabdomyolysis. They also like the elevated potassium as part of the rhabdo vignette. Makes sense if we have renal failure from ATN and an elevated serum creatinine kinase, CK. Question can say that the 44-year-old guy found on the bench in park has an elevated potassium, elevated CK, and oliguria. Diagnosis should be rhabdo, or they'll just say that the elevated CK plus oliguria, and they'll ask you what is the most likely to be seen in this guy. The answer to be elevated potassium. Okay. What's another cause of ATN? Acute ischemia. It's to my observation that acute ischemia is the highest yield cause of ATN on NBME exams. Acute ischemia, highest yield cause. Okay. Even though the medulla of the kidney technically receives less blood flow compared to the cortex, as I mentioned earlier, the USMLE is obsessed with the PCT of the kidney as most susceptible to anoxic/hypoxic injury. This is due to the elevated concentration of PCT ATPase transporters, so acute decreased drop in blood flow causes an acute hypoxia, which causes PCT shedding. NBME loves cellular swelling as part of the mechanism, i.e. acute ischemia. This leads to a decrease in the activity of the PCT ATPases. Remember, PCT is proximal convoluted tubule. This leads to a buildup of the intracellular sodium, which leads to the water stays with sodium, which causes tubular cell swelling. The answer in NBME for why there's cell swelling simply is that a decrease in ATPase activity. This is similar to similar mechanism for why we get swelling plus hemolysis and pyruvate kinase deficiency. Acute ischemia to the kidney can be due to the loss of blood from trauma/surgery, acute arrhythmia, that is to say 30 seconds of VFib, MI, or acute exacerbation of heart failure on 2CK free 120. These conditions cause acute tubular necrosis, not prerenal. Once again, a decrease in flow to the kidney causes prerenal azotemia, will be more subacute/chronic, such as due to NSAID use, recent initiation of diuretic or dehydration. There are rare questions that are exceptions, but that is the general principle. As mentioned earlier, USMLE will give a one-liner where they say, dude had surgery where he lost a lot of blood, plus received many packs of RBCs. 2 days later, he's now recovering in hospital, plus gets oliguria. They don't say anything about brown casts. The answer should be ATN, acute tubular necrosis, not prerenal. Likewise, they'll say woman had surgery plus had 30-second episode of intraoperatively where BP fell to 80/40. The answer should be ATN, not prerenal. Guy has an MI, cardiogenic shock, new onset oliguria, which leads to ATN, not prerenal. Guy has burns covering 50% of his body plus develops oliguria, the ATN due to excessive fluid loss, acute decrease in perfusion to kidney. Acute exacerbations of heart failure causing ATN is a difficult one since heart failure is classically associated with prerenal from chronic decrease in blood flow to the kidney. But in acute exacerbation of heart failure, we have acute significant decline in blood flow leading to ATN. As I've said, it's on free 120. Okay. We're 1 hour and 2 minutes and counting and a few seconds above that, right? So page 86, wrap up on 100 hopefully. Around that. Other renal conditions associated with ischemia. Diffuse cortical necrosis. Diffuse cortical necrosis is a term thrown around sometimes and causes confusion for students. I don't think I've ever seen USMLE assess this. I've only seen it show up rarely as an incorrect answer choice. Diffuse cortical necrosis is simply considered an extension or of ischemic ATN, where DCN, where the diffuse cortical necrosis can occur in severe cases of ischemia, that is to say obstetric hemorrhages. You can be aware of it, that it exists, but don't worry about it for USMLE. If you do see it, it's probably more likely to be a wrong answer based on what he's saying. Renal papillary necrosis. Renal papillae equals parts of the kidney where there's collecting ducts that meets the ureters. The answer in USMLE for a red/dark urine in a patient with sickle cell. In contrast, if the sickle cell patient has a renal condition plus no blood in the urine, the answer would be FSGS, as mentioned earlier. RPGN, or again, this is renal papillary necrosis, is a loss of the renal medulla from the ischemia, but unlike ATN, the etiology is usually more subacute or chronic. NSAIDs are a notable cause in this regard, where the decrease in afferent blood flow due to the decrease in vasodilating prostaglandins over weeks or months causes the medullary blood flow to be slowly choked off. Renal papillary necrosis can occur more acutely in sickle crises, where sickling within microvasculature feeding the medulla results in focal pockets of ischemia. Pyelonephritis, discussed later, can also cause renal papillary necrosis due to the inflammatory compression of the medullary microvasculature. There's one NBME question that I recall where the renal papillary necrosis is the answer due to infection, but I'd say overall the highest field point is just remember that the red dark urine in sickle cell means you're going to have renal papillary necrosis. Interstitial nephritis, exceedingly high yield renal condition often confused with acute tubular necrosis, aka interstitial nephropathy or tubero-interstitial nephritis/nephropathy. Interstitial nephritis, okay. Think of this as an allergic reaction of the kidney. 4 to 5 questions will be an NSAID, beta-lactam, or cephalosporin, followed by getting a macropapillary rash and white blood cells, eosinophils, in the urine. This presentation is textbook/pass level. Only 50% of the vignettes will mention the macropapillary rash, though. The STEM needs not to say eosinophils either. They can just say the patient is on beta-lactam plus now has a white blood cells in the urine, plus they mention a rash. The answer could still be interstitial nephritis. If they say that the rash, it's even easier, right? 1 out of 5 questions will just say a patient was on an NSAID, beta-lactam, or cephalosporin and now has a mild proteinuria and hematuria. They don't mention a rash on white blood cells in the urine. So that makes it obviously more difficult to figure out. There is also a singular NBME question where they just say a patient has simple peripheral edema due to the NSAIDs with no mention of anything else, and the answer is still interstitial nephropathy. This is more unusual since NSAIDs plus edema classically would be prerenal, but I've seen an NBME assess interstitial nephropathy for this as well, so it is tricky. NBME can also give you a simple vignette of interstitial nephritis and then ask for the location in the kidney that's affected, that is to say the efferent arterioles, etc. The answer should be renal tubule for interstitial nephritis, renal tubule. For example, a 40-year-old male treated with a nephicillin for 6 weeks for MSSA endocarditis, plus now has a macular rash and eosinophils in the urine, diagnosis interstitial nephritis. A 60-year-old female using naproxen, an NSAID, for 6 weeks for her osteoarthritis has peripheral edema. The answer should be interstitial nephropathy. A 35-year-old female has recently finished a 10-day course of cephalexin, has mild proteinuria and hematuria. The answer should be interstitial nephropathy. 35-year-old taking ibuprofen has a macular rash and eosinophils in the urine. Question asks where in the kidney is messed up. The answer should be renal tubule. Student says, but don't NSAIDs affect the afferent arteriole? Well, yes, but this particular presentation is clearly tubulointerstitial nephropathy. I haven't seen them be ambiguous here with NSAID plus peripheral edema alone, where you have to debate whether it's interstitial nephropathy or prerenal. They'll either ask one or the other. So usually, even though it's tricky to identify which one is which, they probably only have one or the other as the answer. If you have that, if they're forcing you to actually use the bare minimum information. We're on 87 now. Renal tubular acidosis. Quick notes before discussing RTA. Mud piles, mnemonic for high anion gap metabolic acidoses, methanol, uremia, renal failure, DKA, which is diabetic ketoacidosis, fenformin, a drug you don't have to worry about, iron, isoniazid, lactic acidosis, ethylene glycol, salicylates, aspirin. Anion gap is calculated as sodium minus chlorine plus bicarb in parentheses. So basically sodium minus chlorine minus bicarb. Normal range is 8 to 12. High anion gap would be 13 or greater. USMLE really does not care that you need to know the specifics of types 1, 2, and 4. The way they assess this by you knowing this is a type of normal anion gap at metabolic acidoses, that is to say it is not part of mud piles. So for example, you'll get a 15-line massive paragraph plus tons of lab values plus have no idea what's going on. But then you calculate the anion gap as 12, normal range is 8 to 12, so you can eliminate all of the mud piles answers choices such as lactic acidosis, DKA, and ethylene glycol poisoning. And you're left with, as I say, Crohn's disease or renal tubular acidosis. Then you just say, well, this clearly isn't Crohn's disease, so it must be renal tubular acidosis. That is how I would say 4 to 5 RTA questions show up. So RTA type 1, decreased ability to secrete hydrogen in the cortical collecting duct or protons, right? RTA type 2, decreased ability to reabsorb bicarb in the PCT. And RTA type 4, renal resistance to aldosterone or hyporenemic hypoaldosteronism. Hyporenemic hypoaldosteronism, okay. Type 4 presents with hyperkalemia, the others do not. Type 3 apparently is hyper-rare. Type 4 will be a patient who has Addisonian-like picture, i.e. decreased sodium, elevated potassium, decreased bicarb, but the vignette will present in a patient who has a chronic renal failure. Type 2 can be caused by Fanconi syndrome, discussed more in table below. Type 1 apparently have renal parenchymal stones, i.e. stones in the actual tissue of the kidney, rather than within the tubular lumina as with traditional nephrolithiasis. As I said, the key point is that you just know that the renal tubular acidosis is a normal anion gap and not part of med piles. That will cover you 4 to 5 times. Okay. Other random renal conditions. Tumor lysis syndrome. Tumor lysis of cells, especially leukemic, by the chemoradiotherapy leads to release of uric acid and phosphate that can overwhelm the kidneys and cause crystals, namely from uric acid. USMLE loves asking what you can be given to prevent renal failure in patients undergoing chemo. The answer should be allopurinol. Or they'll ask for MOA of drug that can prevent renal failure. The answer should be xanthine oxidase. The answer on the arrows USMLE wants for what will be seen in the blood tumor lysis syndrome is the same as the renal failure, except that we also have an elevated uric acid. Okay, what about Fanconi syndrome? Inability of the proximal convoluted tubule to reabsorb lots of stuff. Shows up on NBME as an arrow question where they ask about the reabsorption of amino acids, glucose, bicarbonate, and phosphate, and the answer is a decrease for all of them. Since bicarb reabsorption is impaired, this can lead to RTA type 2, but USMLE does not really care. The key point is that the decrease for the reabsorption of the above substrates. For whatever magical reason, an important cause of Fanconi syndrome is the consumption of expired tetracyclines. Well, that's interesting. Don't confuse Fanconi syndrome with Fanconi anemia. The latter is an autosomal recessive aplastic anemia with hypoplastic thumbs/radii. I've made YouTube clips discussing this. So not the same thing, different thing. Okay? So Fanconi syndrome, inability of the PCT to absorb lots of stuff. Fanconi anemia, well, it's an anemia, right? It's hypoplastic thumbs, it's an autosomal recessive aplastic anemia with hypoplastic thumbs/radii. Radii, okay. Heart nut disease. Inability of the PCT to reabsorb tryptophan can cause a niacin or B3 deficiency in theory, since tryptophan is a precursor in niacin synthesis. This is more just textbook self-aggrandizement, to be honest, and that's been parroted over the years. Can't say I've seen this ever assessed once, just mentioning it here. Otherwise, I'll get some umbrageous student popping into my DMs about it. Okay. It's kind of interesting. He uses the word umbrageous there, but yeah, whatever. The variation in word choice is certainly one of potential interest to some people, I guess you could say. Cystinuria, cystine stones, hexagonal, can occur in young adults due to the inability to reabsorb the COLA, C-O-L-A, dibasic amino acids, cysteine, ornithine, lysine, arginine. Cysteine is 2 cysteines put together. Cystinuria can be diagnosed with cyanide nitroprusside test. Hepatorenal syndrome, nonsense diagnosis on USMLE that will sometimes show up as an incorrect answer/distractor answer choice. Apparently, liver failure can sometimes cause a renal failure via obscure mechanisms. Renal biopsy will be normal almost always. So it could be an answer if it's, if it has a certain presentation. But realistically speaking, if you see hepatorenal syndrome, that's probably supposed to throw you off. It's not the answer, probably. Thin glomerular basement membrane disease. So thin glomerular basement membrane disease, benign familial condition in which the patient can have mild hematuria. Thin basement membranes allow for passage of small amounts of RBCs. No treatment is necessary. And I'm going to take a break here, I believe. We're on page 88 right now. I'm on 1 hour and 15 minutes and counting, in a few seconds, of course. But I will be back with you in a bit. Just skip ahead if you're watching the video in recording. Okay, I am back. Let's see. We're on renal vascular hypertension. So let's talk about renal vascular hypertension. Renal artery stenosis. Narrowing of one or both renal arteries due to the atherosclerosis that causes an elevated renin-angiotensin-aldosterone system, RAS, and an elevated blood pressure. Question will be a patient over the age of 50 with cardiovascular disease risk factors such as diabetes, hypertension, and or smoking. Patients who have a pre-existing hypertension causing atherosclerosis leading to a RAS will RAS in this case, renal artery stenosis. So don't confuse renin-angiotensin-aldosterone system RAS with the renal artery stenosis RAS. But anyway, leading to renal artery stenosis will often have a 10 to 20 year background hypertension. Then it becomes accelerated over a few months to 2-year period. That what this means is that the slowly developing atherosclerosis in the renal arteries finally reaches a point at which the kidney is unable to maintain autoregulation and the renal artery stenosis is now clinical, i.e. accelerated hypertension of significant elevation in BP within 3 months, for example. Another way USMLE will give you a renal artery stenosis is by giving an elevated BP in patients with significant evidence of atherosclerotic disease. That is to say, history of coronary artery bypass grafting, intermittent claudication, and then ask for the most likely cause, which would be renal artery stenosis. You have to say, well, he clearly has atherosclerosis in his coronaries and aortoiliac vessels, so that means you'll have it in the renal arteries too. Question can say older patients with carotid bruit has recent significant elevation in blood pressure. When asked for diagnosis, the answer should be renal artery stenosis. Similar to above, if the patient has atherosclerosis in one location, i.e. the carotids, then he or she will have it elsewhere as elsewhere too. High yield factoid about the RAS is that ACE inhibitors or the angiotensin receptor blockers will cause renin and or creatinine to go up. This is why high yield point, that is often overlooked and is asked on NBMEs. I have not seen NBME care whether it's uni or bilateral in this case. Kidney can autoregulate across flux and perfusion. Patients with already compromised renal blood flow are more sensitive to the subtle decrease in filtration fraction that occurs secondary to ACE inhibitors /A or B use, so renin/creatinine is elevated. If USMLE gives you a unilateral renal artery stenosis, renin is only going to be elevated from that kidney. The other kidney will not produce the elevated renin. After renin and aldosterone levels are obtained, the MR angiography of the renal vessels is what USMLE wants for the next best step in diagnosis, MR angiography. Also, remember, ACE inhibitors and ARBs will cause renin and or creatinine to go up in the case of renal artery stenosis. Very strange. Good to know. Fibromuscular dysplasia. The answer on USMLE for narrowing of the renal arteries in a woman who's 20s to 40s, not the same as renal artery stenosis and not caused by atherosclerosis. If you say broadly renal artery stenosis, that specifically refers to the atherosclerosis of the renal arteries in patients who are greater than 50 years of age with cardiovascular disease. Fibromuscular dysplasia is tunica media hyperplasia, not dysplasia despite the name, that results in a string of beads in appearance of renal angiogram. So that's the little string of beads presentation for fibromuscular dysplasia. MR angiography is the answer on NBME for diagnostic modality, can affect the carotid vessels. A 2CK surgery question gives FMD vignette and also says that there's a 25% occlusion of one of the carotids. Polyarteritis nodosa, or PAN, P-A-N. So polyarteritis nodosa is discussed in the cardio PDF. This is a medium vessel vasculitis that causes a string of pearls appearance in the renal vessels. This can be confused with FMD, which is the fibromuscular dysplasia. Just want to make sure I'm saying exactly what it says. Okay. This can be confused with fibromuscular dysplasia, but know the difference in the imaging. So let's go show the imaging right here back to back. So here's FMD, and here is polyarteritis nodosa. FMD shows more beading along the larger proximal arterial vessels, whereas PAN shows pearls more at the vascular termini, which is more which the more proximal parts more likely to be spared. Okay, yeah, I can see it. This looks more like a tree with little Christmas lights on it, and this looks more like beads. So anyway, back to polyarteritis nodosa. Angiogram of Pan shows pearls that are more distal in the renal vasculature. Fibromuscular dysplasia, in contrast, shows more proximal bleeding, which the termini not as conspicuously involved. There is an NBME question where they list both PAN and FMD as answer choices and relies on you knowing the angiogram is to the left angiogram to get it right. They don't mention hepatitis B, but the answer is PAN. That's why I'm harping on this here. Causes fibrinoid necrosis, can be caused by hepatitis B, spares the pulmonary vasculature. What about renal artery thrombosis? The answer in USMLE for hypertension in a neonate following umbilical artery catheterization. USMLE simply wants an elevation in renin and elevation in aldosterone as the answer. It sounds weird, but you need to know umbilical artery catheterization is a major risk factor for renal artery thrombosis in neonates. 2CK NBME question gives a brief umbilical artery catheter insertion in kid born 26 weeks gestation in order to monitor blood pressure for a pneumonia. 3 weeks later, he has an elevated blood pressure, 128/86. The answer would be elevated renin, elevated aldosterone as an answer. Blood pressure in term neonates should be between 60 and 40. In a preemie 29 weeks gestation, it should be between 50 and 30 according to Google. That's pretty low. So, I mean, we are on page 90 right now. Where do we want to cut off? I don't know. I think it finishes at 103, so I could cut off at 91, I guess. Urolithiasis. Urolithiasis is a broad umbrella term that refers to both nephrolithiasis and ureterolithiasis. Diagnosed with non-contrast CT of abdomen and pelvis. KUB, X-ray of kidney, ureters, bladder can be done, but it isn't as sensitive, although below I show an X-ray. So here's a stone type, and then here's the high yield points. So calcium. This is the most common type of stone. It can be a calcium oxalate or calcium phosphate, although I've never seen USMLE once assess or care about phosphate stones. Most young adults with idiopathic kidney stones will have a normocalcemia and hypercalciuria, that is to say normal serum calcium but elevated urinary calcium. USMLE will give you a healthy male in his 20s with sharp pain in his flank or groin, plus RBCs in the urine. The answer should be urolithiasis. Crohn's disease and disorders causing fat malabsorption increase the risk for calcium oxalate stones because of elevated fat retained in the GI tract, causes chelation with calcium in GI tract, which causes a decrease in calcium available to bind oxalate, which causes an increase in oxalate reabsorption by the GI tract, which causes urinary oxalate. Primary hyperparathyroidism and malignancy causing hypercalcemia are high-yield etiologies. Milk alkali syndrome, elevated calcium plus elevated bicarb plus calcium stones. Textbook scenario is a patient taking too many antacids, but vignette will usually not mention this, and it will simply be a diagnosis of exclusion, that is to say, you eliminate to get there. Ethylene glycol, antifreeze, and hypervitaminosis C can cause oxalate stones. First step in prevention and treatment of stones is adequate hydration. Thiazides can be used to prevent recurrent stones by decreasing urinary calcium. NBME has a question that asks why. The answer should be elevated calcium reabsorption. Elevated reabsorption of calcium. In theory, alkalinization can help treat oxalate stones, and acidification of the urine can help treat phosphate stones. What about struvite stones? Composed of ammonium and magnesium phosphate, formed in elevated pH in the presence of urease plus urease-positive bacteria. Klebsiella, serratia, and proteus are high-yield causes. These stones are large, ram horn-like, and the image is high yield. Struvite stone, okay? Apart from the adequate hydration, treatment is acidification of urine with a ammonium chloride plus surgery. NH4Cl plus surgery, okay. Uric acid. Uric acid stone. Seen in patients who have gout, not complicated. First-line treatment for chronic gout is xanthine oxidase inhibitors, that is to say allopurinol and febuxostat. They are preferred over uricosurics, meaning a elevation in urinary excretion of uric acid, like probenazide and sulfenpyrazone, because the latter agents elevate risk of uric acid stones. Probenecid and sulfenpyrazone inhibit organic anion transporter OAT, which normally functions to elevate the absorption of uric acid. Weird factoid about the probenecid is that it can help maintain serum beta-lactam levels since the latter are excreted by OAT. There's an NBME question around, which is again, OAT is the organic anion transporter. So excreted by the organic anion transporter. There's an NBME question about around somewhere that asks about this. Sometimes old school docs will put a patient on a beta-lactam and probenecid. Don't be confused by this. This patient doesn't have gout. It's just it's just a way to decrease the renal excretion of the beta-lactam. What about cysteine stones? Cysteine. As mentioned earlier, cysteine is two cysteines put together. Cysteine stones are hexagonal, can occur in young adults due to the inability to reabsorb the CoLA dibasic amino acids of cysteine, ornithine, lysine, and arginine. Cystinuria can be diagnosed with cyanide nitroprusside test. Miscellaneous, acyclovir for HSV and shingles and indinavir for HIV can cause crystal nephropathy, not particularly high yield, but worthy of 1 to 2 lines here. Now we're talking about cystic kidneys. Cystic kidneys on page 92. So I suspect the next video will probably be maybe 1 hour to 1 hour and 15 minutes if we want to wrap it up in another video. I don't feel too crazy right now, but I would also don't feel so enthused for doing this right now either. So I'm going to decide to wrap it up and then go back into it maybe later today or go into it tomorrow. So if you watched this video, hopefully it was a good use to you. Otherwise, thank you. Have a great rest.